All right, folks. I'm going to get started straight up 6 o'clock. I want to make sure we record this. I talked with Rob today, so everybody gets not able to attend right now for the 8 of you that are here. So listen, I emailed you guys. Some of you guys have already done it. Some of you have not, but we have got to get y'all done in the state EMS class, where y'all have got to go onto the website and get everything situated. I sent instructions. If you're required to do it, you have an email from me in Canvas. Some of the ones can email me back. It'll come straight from Canvas into my ARES email, and I do my best to try to answer it pretty quick. But listen, if you're talking about a fee or anything like that, um, Rob said, have you guys pass the feedback to us. You're not responsible for it. There's an option to have an employer do it, and they just pick us in the list. If y'all understand what I'm saying. So when you're doing your drop down bar of your employer, click on ARES, and the fee comes back to us. So you shouldn't be out any money. If you have been out money, please send me an email, and I will make sure to pass that on to Rob. I just want to make sure we're all stays in the loop. So hang on, I got the wife's texting, so it's important. I try to make sure to pay attention to that. So listen, I know there's been some confuciousness, might I put it, but I've sent out some very lengthy emails about who needs to catch up, who's behind, and there's a lot of people that have caught up. There are some people in our class that is no longer around. They were unable to participate due to personal reasons, or life sucks sometimes, and I hate that we had to lose some, but some have left. I've spoke to very few of them to interest any assistance that I could provide, help them get situated. So we're trying to make sure that everybody's up to par. I'm paying very close attention on who's, your grades, who submits it when. And if you've all noticed that everything has been locked down, all the tests are locked. You can't access any test until the night of the class. It locks 5 days later. If there's any issues with you not being able to attend, or your grades get low, or there's just life gets in the way, please make the time and arrangements to set up a meeting with myself, and I'll include the class coordinator. And three of us will talk. We get it. We understand. We all have lives ourselves, and sometimes things just get in the way. But please feel free to talk with me. Maybe that we can work something out. Maybe I can help you in some ways if your grades get low. But my point behind this is make sure that you communicate about things. If I don't know things are going on and all I'm doing is paying attention to your grades, I'll see you get behind, and I can see how long that y'all have all spent in certain chapters, how long you've been into the Canvas program. So all that's noted. And back to that, I've said this before. I want to make sure I say it again. Your attendance code needs to be written down, because you're going to have that code so you can take your test. If you don't have that code, you can't take your test. So, unfortunately, we're still having some issues out of the program. So you still need to email Rob all the acquired correct information and the date that you were either tonight for in class, or the date that you watched the test or watched the class. Because if it's after the date that I'm allowing you to extend to take the test, you and I will have to discuss some other measures for for me to unlock that test for you. Not being ugly, not trying to be rude. I'm just trying to. We're getting closer to the end of it, and we're going to make sure that we can own up and we all be adults about it and move on. But if there's issues, please come to me and we'll talk about it. Um, we're gonna unfortunately have to talk like this. We all see that screen. I'm sorry y'all see all that crap at the bottom where my screen is, but for some reason my iPad is dead as a hammer, and it will not allow me. Um, 2 seconds. Let me answer this. All right, so obviously I'm sorry, all my notes are down here at the bottom and you see my mouse running around crazy. Maybe you see it, I don't know if you do or not. But I'm sorry. So I normally write all my notes down here and I see it on my iPad, but my iPad is not charging. So sorry. Here it is. That's what we got for you. All right. So we talked about the national EMS education standards. It's the same thing we do about whatever chapter we discuss. We're gonna go over some bleeding tonight. Talks about the blood, path, how the blood goes, what's in the blood. We want the blood to go round and round, not seep out the body. That's kind of an important part. Just keep it inside. We'll go over all that. Pathophysiology applies fundamental knowledge of pathophysiology of respiration and perfusion to a patient assessment of management. So we know that it's kind of one of those that's neutral for all of them, but we have to talk about that. We'll go over. So bleeding can be external and obvious, or internal and hidden. So sometimes some of your signs for internal should be weakness, shock, and I guess the last part is death. Unfortunately, that's where we go. Uncontrolled bleeding is the most common cause of shock, followed by traumatic injury. You need to stop it, assess that bleeding. If you notice it, fix it. Don't go through your whole your skill station and let that pump just keep blowing of blood, because guess what? Eventually it's going to dry out and you're going to fail. Fix the bleeding ASAP. Hint, hint, hint. Click. Why don't you go forward? All right. So some more over now the physiology of the cardiovascular system. So we know that's the brain. Talks about the brains and parts of it. The pump. You got the heart. That is the pump of the body. We have our lungs, we have all of our internals and uh, lower parts of the body. We have all those. So we have the pump, the container, and the fluid. So that's the three main parts. So the container is all the blood vessels, and the fluid is the blood and bodily fluids. Well, sometimes I don't want them on me at all. Y'all can keep your own fluids. But make sure you know the three parts. It's kind of important. Some way we keep our blood going around our body. All right. So the heart, it needs a rich and well distributed blood supply. Why did we need that? Why do we need blood throughout our body? What is carried in the blood that is important to our body?
Oxygen.
Keep on, bro. That was just supposed to say this is a question. Somebody just beats me to it. Oxygen. Our body lives off of oxygen. How much oxygen is in the air? Somebody tell me. What percent?
I think it's 79 or
What does the body take in? How about that? That might be a better question. I'm sorry.
is it 21?
So 21%. So our body takes in 21% oxygen from what's out in the air. It depends on hydrogen, all those other little particles that are in the air. What out of that 21%, what does our body use? Somebody know? Take a guess. It's not gonna hurt no feelings.
I want to say 15, but I don't think that's right.
You are very, very close. If we were playing horseshoes, you'd still win. So it's 16%. So our body uses 16%. So when we exhale, we're getting rid of 5% of oxygen that's not really used, but it's better to have more than less. So if we go into an oxygen deficient area, we're still shooting for that 16%, but our body is stuck on working on 16. So that's why it's important to know 21% of oxygen is taken into the body, 16% of that is used. Uh, we displace 5% plus all the other crap that we blow out of our body. So it's just like I said, I'm full of useless knowledge, and that's part of it. Um, so here, what we need to know is the heart needs a rich, well-distributed blood system, which has two paired pumps. You'll have your atrium and your ventricle, which is your upper and your lower blood vessels. Blood leaves each chamber through a one-way valve. So it's the all right. So let's see how we think about this. A one-way valve. When I say a flapper valve, does anybody know what I'm talking about? I know that's very broad, but so you have a flapper valve in your heart that when the blood can only go out, but it can't go in. So as long as there's blood pushing out, if there's a backflow of pressure for all the firemen out there, think about this. You have the same thing in your fire trucks. You have your one-way valve, you have a flapper valve, so it's just like the same thing that's in your high rise for a sprinkler system. It lets it flow out. But anytime there's a disruption and they want to bring the pressure out, it does not allow it. So those flapper valves, the one-way valves, stop. They shut the system down and they hold the pressure that's in there. Now, it's the same thing about starting an IV. You can hit a one-way valve, and that valve, you'll get a bump in your arm. You'll be able to, the further you go in your career, you'll hear people talk about, oh, that's the valve in the arm. There's multiple valves in different places, but the heart has these valves, so it makes it go in one direction. So there's not a backflow of pressure or a change of flow that messes things up. So the heart has this built into it, so that one-way valves always flow. Now, none of us really want that valve to be shut off, because that's very important that we keep the pressure going. But just remember that all these one-way valves, the heart pushes it all in the right direction. All right, so here's some cool pictures. I don't expect you to remember this, because when you go through A&P, you will have to know this inside out. Just remember your supravena cava. Your purple is going to be your pulmonary, because that is taking oxygen to the lungs. Then you have your right pulmonary. So that purple and all the purples are going to the lungs. So you'll have your right atrium right here. Your inferior vena cava is going into the heart. See the pressure? See how it's going? Going in and around. So it's cleaning the blood that's out. It carries oxygen poor blood from the lower part of the body. Wow. So look right here. The supravena cava carries oxygen poor from the head and the upper body. So you can kind of memorize. You can have your own mnemonic there. Super means top. Inferior means lower. I got all these things built up when I was in school, so I remember them. So these are kind of the bigger parts that you need to remember: is your supravena cava, your inferior vena cava, where your right atrium is, your left atrium. Those are your kind of important things. See, shows right there your left ventricle. You just need to know those. Just kind of helps you out, so you know which way blood goes in, blood goes out. All right, so your blood vessels. Guess what? The yawning's back. Huh. All right. So types of blood vessels. We have the arteries, the arteries, arterioles, and the capillaries. Whew. All right. So the arteries carry blood away from the heart. So you have your big valves, and they're pushing the blood away. So it becomes smaller the further the way off from the heart. So like the feet, you have a very small one versus what you're going to have in the femoral artery or in your arm. So you're going to have smaller areas. As blood flows out of the heart, it passes into the aorta, which is the largest artery in the body. So if you cut that one, you are done. There ain't no fixing that shit. You ain't gonna make it. I'm sorry. That's the easiest way to remember it. So if you have a cut to the aorta, tonight, I'm sorry. We're gonna pray for you. We're gonna say you were a good folk, but I can't fix it. It's your arterioles, smaller vessels that can connect the arteries and the capillaries pass among the cells of the body and link arterioles and venules. So it's all intertwined, and they have. But remember, when it all goes back to the heart, it goes in and out in a roundabout way. It's not a whoops. I'm gonna change my chat back. Sorry, I don't know how to do it. There we go. Sorry, I'm talking to myself, y'all. I haven't sent a private chat on here, so I don't know how to change it back. There it is. All right. Next. All right. So you're talking about your venules and your veins. The venules are very small and they thin. So those are the ones that you may get, like your busted blood vessels in your arm and your hands. Those are kind of common. You may have them in your legs that you'll have from pumping stuff. Your veins are the ones that we want to poke. We want to put needles in. That's the way we can put medicine through, because we know that they're going to the tissues in the heart, and they got that one-way flow. It's better to get it in a vein, well, obviously an artery, but we don't try to stick arteries. I've accidentally done it twice in my career, and I couldn't get that shit to stop. I was like, oh god, what am I doing wrong? Both done by mistakes. I don't want to ever do that again. I can promise you. All right, so the blood vessels in the blood. Oxygen and nutrients pass from the capillaries into the cells, and waste and carbon dioxide diffuse into the capillaries. This transport system allows the body to rid itself of waste products. It's the same thing that we're talking about. It's in your mouth, out your butt. It's the same thing that the blood is doing here. It's got to get clean. Well, the waste has got to go somewhere. So where does it go? It's going to go through the blood vessels. When it gets cleaned of its own, there's waste. Well, the waste has got to go somewhere. All right, here's some blood contains red blood cells that are responsible for the transportation of oxygen to the cells and carbon dioxide away from the cells to the lungs. Red blood cells, I read that one. All right, so blood vessels. You have your white ones, your platelets, and your plasma. Oh, Lord. I don't know if y'all can see this because I know my screen's real small. But there's your platelet, the little purple one. It's kind of cute. And your red blood cells. More look on this big picture, kind of have the clear inner side in there, and your white blood cells. Everybody knows that you want a higher white blood. You don't want a higher white blood count because you're going to end up having an infection. And that's how we tell. We check your when we pull it out, we check your platelets, what your blood levels are. If we see a high WBC, we know we're like, uh-oh, there's an infection somewhere. We need to find out. So as y'all can see the color change. So I put this in here. This to me is important. I think y'all need to understand how the blood is made up. So the liquid components of the blood, you got plasma. It is made of water. I'm not going to taste it to see how salty it is. 92% of it is water. 6 to 7% is protein. The remaining 1 to 2% contains electrolytes, lipids, enzymes, clotting factors, and glucose. Comprise approximately 54% of the blood volume. So think about that. That's a lot. That's 97%, 92% is water. No wonder I feel bloated all the time. That may be why. It's the blood. I'm gonna say that that's the reason. But this is the way the body's broke down. So y'all kind of understand a little bit more that you do have a lot of water in your blood. So when we turn around and put like lactated ringer, which is we hang LR during a traumatic incident, we're looking to replace some of these electrolytes, the clotting factors there, and it is thicker than normal saline. It has a component of holding a fluid replacement. Now, normal saline is just like water. So we're adding more water. Hey, is my cursor moving around when I'm sitting here talking, or is that just I see it on my end like I'm talking on my hands? You may tell me. Make me feel good.
Yeah, it's moving around.
All right, good. So that's me talking with my hands, just FYI, because I'm talking with my hands all in my house and ain't nobody paying attention to me. All right, so when we put normal saline in here, we're not adding to any part of this. All we're doing is reducing this number down percents. We're adding more water to the body as a replacement or a hydration. It's not going to fix anything. LR in a traumatic incident, when there's blood leaving the body, LR is going to help. LR will help with the replacement and the fluid there. All right, so blood vessels. Let's see here. Blood clot formation depends on several factors. You have your blood status, changes in the blood vessels, walls, such as a wound. Let's see how it is. So if you already got a bruise, well, the bruise is going to help get stopped by the blood clots, which we know that. It's all us, even if we cut ourselves. And then how rich is the blood? Does it have high iron? Is the clotting factor that's in the blood, do you have anemia where it's a little bit lower? So that's where we think about that there. When tissues are injured, platelets begin to collect at the site of injury. Red blood cells become sticky and clump together. Protein in plasma forces the development of clots. So right there is what it tells you is the red blood cells. So the way I look at it is they expose them to air, and the red blood cells become sticky. Well, that's what starts the process. Well, then the protein in the plasma back up to the blood, and they're like, all right, so now we're going to start making this clot. That's the reason why when you wrap something and you keep it from bleeding, you don't pull it off continuously, because all you're doing is you're pulling the clot off, and it has to restart the clotting factor, which is no good to none of us because all you're doing is pulling it off, which is not helpful. We're going to end up messing ourselves up. We keep doing that. So once you get it situated, I'm trying to do two things at once. Y'all bear with me. Y'all know I've already told y'all I'm slow. So once you bandage something and you wrap it, keep it covered. Don't pull it off. All right, back to y'all now. All right, so functions of the blood. We talked about this a little bit. So we know it transports of gases. You got your oxygen and carbon dioxide that's always there. It's either going in or coming out, going to the lungs. We talked about that. It carries nitrogen, excretion, proteins, antibodies, and leukocytes. So that's the big part of the functions of the body is what it does there. And it regulation. So it carries hormones, water, salt, enzymes, chemicals, body temperature, which pretty sure y'all realize that. So what it does with the body temperature is we know blood stays warm because it goes through our body. It has a friction motion there that does help, but the heart's pumping it, warms it up. That's the reason why when we get chills, like the outer part of our body gets cold first, because it's the smaller blood vessels and it's the furthest away from the heart. Always keep your core warm, the better warmer you'll be. So your automatic nervous system, let's see here, monitors the body needs for movement from movement to movement, and adjusts blood flow by constricting or dilating blood vessels, automatically redirects blood away from one of the other organs to the heart. So it's shutting down what's not important to keep the heart functioning. So it shuts down to the heart, the brain, the lungs, the kidney, and then an emergency. Those are your core generator. Let's put it that way. Everybody knows that. Keep a generator running, you got to have certain core parts: spark plugs, fuel. Uh, I'm not a mechanic, just went blank. There went that analogy, but you understand what I'm saying. So, when the body starts to shut down, those major important parts of our generator has to stay functioning: heart, the brain, the lungs, and the kidneys. Because guess what? If they don't, we start shutting down. So, and it adapts to change conditions to the body to maintain hemostasis and perfusion. If the system fails to provide sufficient circulation for every body the part perform function, the shock results. Blah, blah, blah. So that's where if we start losing volume of blood, our body's going to start having issues and we're going to start going into shock. So we want to keep the core as blood rich as we can. Huh. Maybe we have to elevate the feet and help them in that part so we can keep them from shock. There's different avenues that we need to do to keep the body from going into shock. Now, talking about pathofusion and perfusion. So, perfusion is the circulation of blood within an organ or tissue to meet cells' needs for oxygen, nutrients, and waste removal. That's it. All right, so the pathofusion again. You got to talk about the speed. The speed of blood flow must be fast enough to maintain adequate circulation throughout the body to avoid clotting. So the slower it goes, we know it's going to get sticky and then it's going to start clotting. Well, we don't need that in our body. We need that shit to flow. We need our pipes to be open and we need to be pushing some water. That's what the body wants. So faster the better. Must be slow enough to allow cells time to exchange oxygen and nutrients for carbon dioxide and other waste products. Some tissues need a certain supply of blood, while others can survive with very little. I'm trying to remember which ones that don't need a lot of blood, and I had it earlier written down, and obviously my daughter decided to take that away from me. All right, so all organs and organ systems of the human body depend on adequate perfusion of properly functioning. Some organs can tolerate interruption of blood supply in even a few minutes without sustaining damage. Death of an organ system can quickly lead to death of the patient. Emergency medical care is designed to support adequate perfusion until the patient arrives at the hospital. That's our objective. That's our overall objective. But that don't mean we do it. We can't always make it work, but we're going to do our damnedest to make it function and do our best to plug those wounds. So y'all tell me what organ is the most important to keep the blood flow to? How'd I say? Which one do we want the blood flow to the most? I'm gonna say y'all slugging a little bit. All right, Daryl. I'm gonna go. I'll give you the heart. But what makes the heart pump? There you go. Ah, you got your brain. So we want the brain to constantly have blood flow. And if you cut off any circulation to that, it's over. Because your generator is out of fuel. It needs oxygen and blood to the brain to function. Well, we need to make sure our key organs keep the blood flowing. And the brain's one of the biggest ones. Why is it not working? All right. So the heart requires a constant supply of blood. The brain and spinal cord may last 4 to 6 minutes without perfusion. The lungs can survive only 15 to 20 minutes without perfusion. Kidneys may survive 45 minutes. Well, not my kidneys, because I'm having to pee a whole lot faster than that. Oh, never mind. Skeletal muscles may last 2 to 3 hours. The gastro tract can tolerate slightly longer periods. Times are all based on normal body temperature of 98.6. Colder temperatures will lengthen survival times. So if you have somebody that's hypothermia, they may live a lot longer. Like you have all these people that are hike up these mountains and stupid crap, like go to higher, all this crap, they breathing on tanks, and that's amazing that your name's in a book now because you went 40,000 feet up. I'm proud for you. If something happens to them, they shut down. Their fine motor growth skills are reduced because of what they're doing. So if they have an injury and something happens, they're gonna last a little bit longer than us because they're working in the negatives, and their body's kind of working at a reduced load already. So that being said, is they're probably gonna I give them probably maybe hour or two, a little bit longer than us because of the temperatures and all that. All right. Some external bleeding. Hemorrhages means bleeding. Where's my notes? Hemorrhage means bleeding. External bleeding is visible. Nosebleeds are bleeding from open wounds, which we should know that. You cut yourself. I have a huge one. Every time I get a brand new pocket knife, I'm going to cut shit out myself. No matter what happens, I don't care how careful I am. But we know we're going to see that because that's an external bleeding. Those bleedings, those types of bleeding is better for us because we're able to hopefully fix it between adding 4x4s, ABD pads, you got your pressures, you got your elevation, you have tourniquets at the last resort. So those types of bleeds are the easiest. Like nosebleeds. Everybody's like, "Oh, I can lean back." No, that's stupid. Don't do that because I don't do vomit. So if you leaning back, means eventually I'm gonna have to play with your vomit, and Chris Wiley don't do that. So I would prefer you to pinch your nose and lean over so you ain't gotta worry about vomiting. That's just me. Y'all do how you want, but I don't do vomit. I don't know if y'all know that or not. All right, the significance of external bleeds. With serious external bleedings, it may be difficult to tell the amount of blood loss. So what we did, I'll go ahead and tell you the rest of this part. Blood will look differently on different surfaces, absorbed in the clothing versus diluted in water. It is important to estimate the amount of external blood loss. Very important. I'm going to say that again. It is important to estimate the amount of external blood loss. Treatment should be based on the patient's presentation and the mechanism of injury. The body will not tolerate an accurate blood loss of greater than 20% of blood volume, which is about 2 pints. Somebody had to tell me how many pints of blood we got in our body. Typically, an adult male. Oh, never mind. It tells you right there. Mickey, 12. Whoa, whoa. We're not talking about beer, girls. Chill out. It's all right. So, an adult male has approximately 70 milliliters of blood per kilogram of body weight. Typical adult female has approximately 65 milliliters of blood per kilogram of body weight. So, that being said, is what we had to do in school is uh, they would take us outside, lay out some different things like some clothing. We used paper, we used concrete, a few different things like that, and they would put out different amounts of water. Obviously, we're not going to pour blood out because you're at a college when I was in paramedic school, but they would allow us to see guesstimate what the. I bet you misheard the question. Put them silver ones down. You're talking about a 12 pack, girl. Chill. So they wanted us to guesstimate the mass of blood loss from what we saw. So it is pretty neat, if you will, want to go out, let's say on your concrete or your driveway, apartment complex, wherever, do it in your tub. Fill up, plunge in your tub, pour out a cup versus 2 cups, and look at the difference of blood on a concrete versus where you poured in the tub or even in the sink. Your guesstimation is going to be completely different because of the way the concrete absorbs it. And a tub is slick, it's smooth, it's going to pull to the lowest point because that's what it's supposed to do to drain the water out. So, and that was one of our tests. We actually had to come close to that's testing us, and we had to either it was a pass or fail. And they didn't really give us a grade in the end. We were all worried about it, but it gave you a good idea for the future how to guesstimate the blood loss on different surfaces, and it's going to be different even with snow, completely different. Now we use water and food coloring so we could actually see it better. Significance of external bleeding changes the vital signs, obviously, because the body's losing pressure. So it increases the heart rate because the heart's pumping. It's got to produce more blood. It's got to get the blood loss. That's where it's leaking from. It's got to increase that internal pressure now that something's decreased the pressure. So your increased respiratory rate, because now your heart's beating faster, you got to get crap moving and going. So it needs more oxygen. There we got it. Got to replace the oxygen that was in the blood. And it's decreasing the blood pressure because of our volume. Our volume is down. All of those things have got to get going. And I'm sorry if y'all heard that. I apologize. All those things have got to get going to make things work in the right way. Because infants and children have less blood volume to begin with, the same effect is seen with smaller amounts of blood loss. They're going to have the same exact effects of right here as we are as grown folk that we think we are because of the volume. Think about that. So if we lose 2 pints versus a 6-year-old that loses 2 pints, we're talking about a mass difference. Mass difference because they are going to be a trauma patient because they've lost 2 pints versus an adult that's lost 2 pints that may just be related to a medical event. So think about the size of your patient. How well will people compensate for blood loss is related to how rapidly they bleed. If you got a slow oozer, it's going to be a little bit easier versus one that's got an inch hole in them. An adult can comfortably donate 1 unit, 500 milliliters of blood over 15 to 20 minutes if they can start the IV right. That's how they started. They stuck. If a similar blood loss occurs in a much shorter period of time, the person may rapidly develop symptoms of hypovolemic shock. The age and pre-existing health of the patient should be considered. Blood loss is an extremely serious problem that demands immediate attention even before the airway and breathing is addressed. Stop the bleeding anytime that you see a massive blood loss. If you walk into your station and if you know you've got SceneSafe BSI done and you see bleeding, address it right then. I'm trying to tell y'all something. Did y'all get that? Address the blood loss right then. If you don't, you will fail. I don't want you to fail. I want you to succeed and go on. But anyway, all right. So, in the age of this person, your geriatrics are gonna react different to us, middle-aged. We're all gonna say we're healthy individuals versus a geriatric or a pediatric. I don't know how else to explain it. If they have other health issues, as in diabetics, versus oh no, sorry, I just went blank. Mickey says I pass out every time I give blood. Well, I don't give blood unless I personally know you. Don't disrespect them. I think it's great that they collect blood. Blood Services goes around and does that because eventually we're going to need it. Hopefully we don't need it overall, but some people come to issues, and I will give blood as long as I know you and I can match your blood. I have a problem with blood service people because they suck at IVs. I'm sorry. It's just my thoughts. All right. Characteristics of external bleeding. Characteristics: injuries and some illnesses can disrupt blood vessels and cause bleeding. You consider bleeding to be serious if the following conditions are present: poor general appearance and no response to external stimuli, signs and symptoms of shock or hyperfusion, significant blood loss, rapid blood loss, uncontrollable bleeding, or significant MOI. I mean, that's just straightforward. I don't know how else to say that to y'all. If you see signs of rapid blood loss, uncontrolled bleeding, or the MOI just makes you go, what in the hell? Do your dangest to stop the bleeding. Fix it. Do your best ability to make it better. I'm trying to think of the words to try to get this through y'all. The things right here are going to be your problem. If you can't fix those, or um, you're having problems stopping the blood loss, you may have to apply that tourniquet. Don't be surprised if you have to put two on. India, is there any way to deal with a significant sensitivity to seeing blood? Mm, uh, no. Not that I know of. I don't know if anybody's aware, but blood has a smell to it too. Large amounts of blood smells. Some people have issues with that. I personally don't have, and the reason why I like to say this now is I don't have a problem with the mask that we're required to wear or not required to wear or wherever you're at, because it masks a lot of smells. I'm okay with that. I actually am working on a truck one night this week, and I'm okay with wearing that mask because I don't want to smell the stuff. Vicky is right. Use Vicks Vapor Rub. I used to, when I was almost full time on the truck all the time, I always kept Vicks Vapor Rub very handy. It went with me in and out because if it got bad, I would just dip my fingers in them and rub my nose, and the patients wouldn't notice it because I wouldn't have gobs of it, but you would love that menthol smell, I can promise you, versus the smell. Matter of fact, I talked to a associate of mine today. He's a PA, and he told me he had COVID about the first week of Christmas, and he still not got some of his smells back. And we were talking about that today, and he was like I had to drain a massive abscess the other day, even though I had my mask and everything on. My nurses are all gagging. He goes like, I didn't really smell nothing. I don't know what y'all's problem is. So to answer your question, India, I'm not real sure about that, and I know sometimes it may get better versus worse. Um, just in time, you'll be able to know. I'm sorry, I wish I could give you a better answer, but I don't have one. Again, so let's talk about this. So, oh no, back there. Just think of it as ketchup. Don't lick it, Travis. I just sorry, my bad. So arterial bleeding. Pressures cause blood to spurt and make bleeding difficult to control. And the reason why it's going to spurt is because every time the heart beats, you're going to have a pump. It's the pumping sensation because the heart is in the pump, and it's going to just squirt blood because there's a way for it to get out. Typically brighter red because it's rich in oxygen. Darker blood has poor oxygen, so that's why it's got waste in it. So think about that. Bright red, oxygenated. Dark red, it's got waste in it. Decrease the amount of blood circulation to the body and drops the blood pressure. Some of your venous bleeding is dark red, low in oxygen, flows slowly or rapid depending on the size of the vein, does not spurt and is easier to manage, can be profuse and life-threatening if not fixed, most likely to clot spontaneously than arterial bleeding. And Mickey says, I have noticed a big difference in taste and smell since having COVID. Well, that's kind of the telltale sign there, love. Like I've told you before, I still have knee pains. Don't know why. My son was never COVID positive, but he has not had smell for, I think we've said like the last 60 days. Don't know why. Have no idea why. Um, but so you'll notice when you have an arterial bleeding, oh god, versus your venous bleeding, it's the slow venous. This is like the, it's just slow, and it doesn't care. It's just gonna clot on its own. But the arterial bleeding is pressurized. So, oh, sorry, I had to get my drink. So it's gonna be under pressure, and it's gonna squirt. It's going to require direct pressure, or if you can't get it stopped, tourniquet in the last resort. But that's the biggest difference you'll see versus the pressure of the body. And it is important too to know what their blood pressure is, know what their pulse is, because we know they're losing blood volume, they're going to be breathing heavy, their blood pressure is going to decrease, and the respirations are going to increase. Stand by. Give me a. Oh no, India, we're good. I got you. Um, I can't figure out how to reply to you. All right. So here are some of the big differences. I don't know, but that hockey dude, like he got the hell knocked out of him. All right, so capillary bleeding, bleeding from the damaged capillary veins, dark red. So see, dark red. It's just sitting there. It looks like a really nasty paper cut. I'm assuming that's a knee, like a knee laceration. And this hockey dude, I don't really know, but I would say that's not capillary, just because of this the flow right there. But uh, just going off a picture. Can y'all see that real well, or do I need to zoom in real quick? Whoops, wrong button. Stand by. It's the user. How about that? Is that better for y'all? Can y'all see that one? Ugh, I don't think that's venous bleeding. All right, clotting. Let's see. Bleeding tends to stop rather quickly, in about 10 minutes, in response to internal mechanisms such as exposure to air, because we know it has a clotting factor. That's the big part, that we want it to clot on its own. Okay, look, somebody, Robert says on page 884. Appreciate that. Thank you so much. So when the skin is broken, the blood flows rapidly from the open vessels because we've created an open path for that blood to leak, and we don't want that. We want it to stay inside our body. So let's stop it. Let's see. The cut ends of the vessel begin to narrow vasoconstriction, reducing the amount of bleeding. Next, the clot forms, plugging the hole and seals the injured portions of the blood vessels. Coagulation. Bleeding will never stop if a clot does not form unless the injured vessels are completely cut off from the main blood supply by direct pressure or a tourniquet. I can unfortunately say in the Middle East, I have actually seen a guy come in. He's an Iraqi. Came in with his arm in one hand, in his right hand, and his left arm was he was carrying his left arm because it got cut off. We didn't ask no questions. We didn't do anything like that. We were just responding. But he had his belt so tight on his left arm that it had quit the bleeding, and he was having to hold it with his mouth. But his left arm that he was hanging was bleeding profusely, and we were all like, "Oh my god! Like what did just like it really just happened?" And it happened. He walked in up to our gate and got cleared and all that. We don't know what was behind all of that or anything like that, but they bleed pretty heavily. Just to let you know, uh, with if it's an amputation. So don't be surprised if that does happen. All right, so clotting. Despite the efficiency of the circulation system, it may fail certain stimulators. So you movement, disease, medications, removal, bandages, thermal environment, body temperature, severe injury. I don't know what you're trying to say there. So Hemophilia is a patient that lacks the blood clotting. Several forms. You have most are hereditary, and some are severe. I mean, you're not going to stop them all. But they'll tell you straight up front, be like, hey, I'm a hemophilia. And you'll be like, I don't think you need an IV today. I'm going to wait. And that's like, y'all love it. When you get to the hospital, like, why did you have an IV? Well, they're hemophilia. Oh, okay. And they won't talk shit to you, but they're still going to give you a hard time. And their bleeding's probably going to just start spontaneously because maybe pressure, maybe they did bump something that will start. All injuries, no matter how trivial, they're all potentially serious, and they all should be transported immediately. I'm not asking you to run lights and sirens in the hospital, but don't just goof off around on scene, talk to the fire or talk to PD, blah, 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 blah. There's a reason why they called you there. Let's get them to the correct facility and get them treated right the first time. That's our job. Let's make them feel better the best we can. Why is it not going? All right, some internal bleeding. This is what sucks because we can't see it. We can only fix what we can see, and we can only handle what we can see. It's easier for us in our realm of work to treat what I can. I like to put. If I can put my hands on it, I can fix it. That's me. If I'm a visual type of person. So internal bleeding is a bleeding in the cavity or space inside the body. Well, I'm pretty sure y'all got that. But it can be serious because it is not easy to detect immediately. Injury or damage to the internal organs commonly result to an extensive internal bleeding and can cause hypovolemic shock. So how are y'all, as your new EMT bases, going to recognize that they potentially can have internal bleeding? Somebody tell me. I'm going to try to fix something while I'm waiting on y'all to answer that question. What are y'all expecting to see during hypovolemia? They're going into shock. What am I expected to see? I'm sorry, you have to wait. I see your statement up there. Give me just a second, please. Nope, sorry, I didn't want y'all to see that. I'm trying to get it brought back up. I got my iPad working now, so I'm trying to get that situated. Ta-da! Let's do this. Come on, work for me. All right, now y'all can see it better. All right, so what we're going to expect to see, and let me check y'all's messages because I'm sure y'all are on point. Low blood pressure. Victoria says, if from an injury you may see dark bruising to the body, vomiting, blood is possible. True. All right, so sorry about that. But your big thing that you're going to see is, like Victoria said, is I'm trying to poke y'all to see the blood pressure change because you're checking your vitals on a regular. So that's where you're going to notice the change, is because the blood pressure is off. You're going to notice the rapid change. All right, good deal. I had to double check something. So that's what I'm expecting y'all to see, is the blood pressure change to see if they're in hypovolemic shock. All right, so some of the internal bleeding. Here's some of the possible conditions that you could respond to. Is you may have an ulcer, which we know. Cherry's hunger, sweating, nausea. So you're more going to get your nausea because if they have internal bleeding, it's going to sit on their stomach, or It's going to pull to an area, so you may also notice bruising. But I get what you're saying about the sweating and the nausea. Their body's is an overwork syndrome. So some possible conditions causing internal bleedings: you have your stomach ulcer, your lacerated liver, ruptured spleen, broken bones, especially ribs or femur, and your pelvic fracture. You'll lose 2 liters of blood in the pelvic before you'll notice a change. It's crazy how much blood the pelvic will hold before you notice anything that's been lost or a super change. You may notice like, hey, the blood pressure changing, but you're like, why is my patient looking like crap? And I don't know what's going on. They may have a pelvic fracture. So your ruptured spleen, those are going to be kind of quick. You may not notice those until the latter stages. The ulcer, you'll probably they'll vomit blood a good bit, trying to figure out what's going on. So some of your MOIs for internal bleeding, often the signs, symptoms of internal bleeding are continuous, or you may come see with ecchymosis. Mechanism of injury, internal bleeding is a high injury MOI should increase your index of suspicion for the possibility or seriousness of the unseen injury. Internal bleeding is possible whenever the MOI suggested that severe forces affected the body: blunt trauma, penetrating trauma, a massive car wreck. Don't ever rule it out until you know what's going on. Don't downplay their injury because you see their mangled ass car and they're like, man, I'm proud I survived that. They're standing, walking, and talking. That's their fight or flight syndrome. They had that dump of epi into their body, and their body's still going, I don't know what's going on. Oh my god, oh my god, oh my god. But outside, you see everything's fine. They're talking, walking, talking, breathing, doing good. The next second, done. They're gonna hit the ground because that fight or flight is out of there. Yes, the adrenaline is keeping them alive, and I have seen it and seen it and seen it where I've had the people die right in front of me because that dump is over, and they've refused service. You ask them all the questions, they know everything. That's just what happens. Unfortunate. You better hope your documentation is really, really good. What time is it? We'll go over 2 more slides and we'll take a break. We may hit the next 3, so we'll finish on a good one. All right. So your DCAP BTLS, this is how you check for signs of injuries. I use these on a daily. And anytime I put my hands on a patient to check them, I'm always noting positive DCAP BTLS, negative DCAP BTLS. I look for it all the time. I'm telling you, these acronyms, these syllables, these verbiage, whatever y'all want to call them, you better know them because they're going to save you over time when you build your rapport on how you put your hands on your patient, how you assess them. You need to look for the deformities, contusions, abrasions, penetrations or punctures, burns, tenderness, lacerations, or swelling. I swear I use them on a daily. Anytime that I'm touching a patient or working on a truck, this is always in my report. That's how you're going to know alpha your MOI if there's a change of status. Hey, give me a second. I'm going to mute my mic real quick. Give me 2 seconds. All right, guys, sorry about that. I'll adapt that to our break. So make sure that you use these DCAP BTLSs. Why won't it go? All right. So in nature of illness for internal bleeding is not always caused by trauma. It can be a medical. They can just, for for any reason just start having any kind of internal bleeding, and we can't fix those. We've got to take them to a higher facility. So possible non-traumatic causes, you have your ulcers, like we talked about, bleeding from the colon, ruptured ectopic pregnancies, aneurysms. Those are all really massive things. We can't fix out in the field, but you need to recognize it when you start checking those vital signs and realizing something ain't right. Some of your frequent signs that are not always present, but you may have the tenderness, like we were telling you, when you assess the abdomen. If y'all remember, I'm a little girl standing on the table over here, showing you how to assess them. When you palpate them and they're hurting in one quadrant, you start on the complete opposite side. They're guarding. They're very tender, like, oh, don't touch me there. It's firm, so when you do touch it, it's like it's like a six pack, but it's hidden. I'm just playing. No, it's just rigid. They don't. It's not comfortable. Anytime you touch it, they got pain or distension, maybe swelling. Signs of internal bleeding, maybe in the abdomen, is due to the swelling. The abdomen is disformed or distended, and we got to fix that. So keep that in your mind. Last one, I'll let y'all take a break after this one. Some in older patients, you may notice your dizziness. I think somebody noted that a while ago. Dizziness, faintness, weakness, ulcers, or other gastro problems may cause some of your vomiting of blood, bloody diarrhea. We already talked about that in the upper or lower GI problem. If y'all remember that. Yeah. It's not always important. It is not as important for you to know the specific organ involved as long as you recognize that the patient is in shock and respond appropriately. If you notice that GI problem, you notice that inability, and there's problems there, let's recognize it. Let's respond appropriately and treat the patient right. So that's why it's important. Check your vitals. Always stay with your patients. Make sure you know what's going on. Assess your patients consistently and move forth. I don't want to go to the next 4 slides just yet. I'll see y'all. I'm actually going to try to munch real quick. I'm sorry, I got hot food. So let's take 15 minutes. I will see y'all at, what is that? Can't do math, went to public school. Let's say 10:15. Shoot, sorry, no. 7. Let's say, somebody help me out here. 15 after 7. How about that? 7:15. I'll see you.
7:13, 7:15.
Yeah, you see, I went to public school. I told y'all my math's not great. All right, I'll see y'all there. 7:15 it is. All right, appreciate it. Thank y'all for letting me eat real quick. I know y'all are probably eating and listening to me, so I had to take a break to eat. I'm starving. All right, so signs and symptoms of internal bleeding. We talked about this all right. So most common is your pain. You'll have swelling in areas of the bleeding. Distension, like let's say if it's a stomach bleed, you're gonna have distension there. If you have bleeding into the chest cavity or lungs, you may cause dyspnea, which is the 1 or 2 word dyspnea. If y'all recall what I'm talking about, it's having trouble breathing. So there you go. You'll have tachycardia, hypotension, and bright red blood that is coughed up. So it's you may notice it like if they cough and they're like, oh my God, I'm coughing blood. That could be signs of a TB, so keep that in the back of your mind. If they're coughing up blood, there could be other reasons. Hematoma, a mass of the blood in the soft tissues beneath the skin. You may have bruising or contusion or ecchymosis may be present initially. So, some other bleeding from the body opening. That can be dangerous. Again, we want to fix that. Bright red bleeding from the mouth or the rectum. Let them tell you that. Please don't palpate that area. Check for it. That'll be assault. So hematuria is blood in the urine, so they're peeing out blood. Non-menstrual vaginal bleeding. Hemotemesis is vomiting blood, and that's either going to be a bright red or a dark red. Coffee grounds in appearance. You may have malaya, as a black, foully smelled tarry stool with this. So we talked about that. That could be GI related, and if it's GI related, those are some of the symptoms you're going to have, and that's the reason why they do have internal bleeding, but it's sticking to the stomach, and that's where it's got to go somewhere. You'll have pain or tenderness cause bruising, guarding, or swelling, possible closed fracture, broken ribs, bruising all over the part of the chest or rigid distended abdomen indicated for possible lacerated spleen or liver. So those are the ones that you're going to see the most. Hold on a second. All right, so when you're going to have like the broken ribs and all that, they'll be painful. You may have a flail chest, you may have a flail segment. Those are going to be the issues you're going to see the most. Is that my key? All right. That's going to be your telltale signs. Look for seatbelt injuries. Look for steering wheels, deformities to the chest. If they won't let you palpate the chest, it's probably going to be a reason. I need to ask why there's going to be a reason. What's going on? Is there any reasons that something happened, or what caught me here tonight? Let me help you out. So let's talk about hyperfusion. It's a hypovolemic shock. It's a change in the mental status such as anxiety, the restlessness, the combativeness, weakness, fainting, dizziness, or standing, change in skin color or pallor. They may just be dark. We don't know what's up. They're just dark skin. Real pale. I'm sorry, real pale. Well, stand by. My iPad dead. Can y'all can see that right? Is that good for y'all? Well, I hope y'all guys can see that. I'm gonna have to keep going this way until my iPad charges back up. All right. Trying to get some things out of my way. All right, so some signs of symptoms of bleeding again. So we'll have later signs. These are some of the last little bit of issues that you're going to see. Maybe like the patients are going to present in their later states of internal bleeding. So you'll have the dull eyes, you'll have the rapid and slow breathing. They are able to respond to light, but they're going to be delayed. They're not going to be as fast as you and I currently are, but they're delayed. So you'll have a weak, rapid, 30 pulse, You'll have a decreasing blood pressure that I hope you realize that you're noting on a chart as you're checking the vital signs. Altered level of consciousness. Patients with these signs or symptoms require prompt transport. So if we realize that our patient is drastically decreasing, we're going to need to transport these people pretty quick because we're going to notice something's wrong. We're realizing that, oh no, my patient's worse than I expected, or they're getting worse. And we need to recognize that. So we're going to have to, in due regards, transport them to the most appropriate facility in the correct amount of time. All right, so scene size. We talk about this every single time. We know what the patient looks like, but how are we going to assess our scene when it starts talking about what our scene size up? So we're scene size up, always scene safety, be alert, potential hazards. As a vehicle crash, ensure the absence of leaking fuel. Make sure that you're safe to be there. If it is okay for you to be there, then that's fine. Let's go. That's fine. Let's move on in. We'll make things work. If you need PD, call them. That's what their job is. They get paid for that, not us. Let's realize that we ain't heroes like we all think we are. That sometimes we need some people with guns. Um, that will be our issue. So make sure it's safe for you and your partner to enter the scene. Mechanism of injury. What do we see? How many patients do we see? Does the mechanism of injury require us to go ahead and call for additional resources? Right now, we're all going through inclement weather. I don't know what part of the country you live in, but Mississippi today was expected to get massive tornadoes and high threats and all that. Thank God we were skipped, but Alabama and Georgia got hammered. I read on one of my friends' Facebook page, he's a meteorologist, that there's several injured and trapped personnel that are over in Alabama right now. So keep those in your thoughts and prayers. Can anybody else hear me? Or is it just me?
Yeah, I can hear you.
All right, cool. Appreciate it. Now I don't know. Maybe check your settings. I'm sorry. All right. Thank you guys. I appreciate y'all piping in and letting me know. I'm not opposed to y'all keying in anytime, telling me to hold up, go back over something. So y'all keep that in mind. So your primary assessment. What does your general impression say? If your general impression is like, this dude looks like crap, treat it like that's what you need to do. Take care of your patient with the most urgency. Treat those wounds. Treat what you see. Provide that comfort care, and always, always, always be nice. Be be gentle. Sorry, I just knocked the drink off the table here. So let's just say, note important indicators that alert you to the seriousness of the patient's conditions. There's several things that you can pick up from just the scene to what you say, general impression. They missing an arm. That's pretty serious. Y'all realize that that's life threatening. Let's fix that. Their gender and age. Just find out how old they are. What past medical histories do they have? That will tell you right there. Oh, Jesus, maybe they are a lot worse. Their belly's not normally that distended. Do they have some internal bleeding? They were in a car wreck 2 days ago. Did they go to the hospital? No. Well, their stomach may be distended because they're bleeding inside their stomach. Always perform a rapid exam. You don't have to touch them, but if they allow you, be like, hey, you look, I'm gonna go real quick from your head to your toe. I just want to make sure that everything's intact. Do your DCAP BTLS on every single thing you do. Arms, legs, abdomen, chest, face, lower arms, check their pelvic. Depends on your situation and your MOI. If you always got to check their pelvic, you need to check for rigidness of the pelvic. You don't need to like check their pelvic, if y'all understand what I'm trying to say. Just be very professional. Determine the level of consciousness using the APU scale. We've gone over that. They're alert, verbal, painful, unresponsive. Times 3, they alert to person, place, and time. Do they know who the people standing in the room are? Are they confused? Are they combative? Do they want to fight you? What's going on? That's something we need to worry about. Airway and breathing. Is their ABCs open by their own, or do you have to open it for them? Is it important that their ABCs are assessed prior to getting there? If you notice that they're not, is it as simple as doing a head tilt chin lift, reposition the airway, or do you have to insert a possible OPA or an NPA? Is that, or do you need an advanced airway? That's something that you can assess from a distance. Hey, how you doing? What's going on? And they respond. I'm pretty sure the airway's doing pretty good because they just answered your question. So that's something you can do from a distance. Let's talk about circulation. What is their pulse rate? Reach up as you shake their hand. Do they have good grip? Do they have dexterity to where they can look at you in the face to shake your hand, or do they have to look at their hand, shake your hand? And when they do that, reach up and like act like you're holding their hand with both of your hands, but you're just gonna check their pulse at the same time. Maybe you're handshaking with your right hand, and then you kind of hold their hand, but your first two fingers of your left hand is checking their pulse. Ding, ding, ding. It's amazing. Some of these things work out really well if you do it right. If you see external bleeding, fix it. Fix it. That's what we need to know. I've told y'all multiple times. If they need oxygen, give it to them. Maybe it's a comfort measure that you're just providing them some oxygen and you're helping them breathe. They may not have had breathing problems, but you're doing something for them, so you're calming them down. All right. Talk about your assessment. Stand by. Transport decisions. Are we going to the most appropriate facility for the most appropriate issues? Just need to know that. If they're having life-threatening issues, let's go to a trauma center. Don't take them to a trauma center when they may just be having, a cut to the finger or been in a quick, a non-deformity MVC and they want to go get checked out. You don't have to take them to the trauma center. They take them to another appropriate facility that can handle what potentially is wrong. History taken. Some of the things we want to know is what got me here today. What is the problem right this minute that you called 911 to bring me here? I know that family's saying this. Your daughter's saying that. I need to know from you, sir or ma'am, what's going on. Why am I here today? Listen to them. Notice obvious, it says right there, note obvious signs of internal bleeding. Look more carefully in this step. This is where you give your detailed assessment. Check their abdomen. Like, hey, ma'am, listen, I just want to look at your stomach real quick. I want to poke on it real quick. I'm not going to lift your shirt up high. I just need to look at it real quick, and I want to make sure that your stomach's not, that your stomach is okay. And just be like, yeah, that looks real good. Thank you so much. And just to treat them with respect. If the patient is responsive during a trauma, is isolated injury with a limited MOI, consider a focused assessment before assessing vital signs or obtaining a history. If you're already there doing something, continue it out. If you're bandaging their head, continue their assessment, head to toe. If you're paused or you've already put the blood pressure cuff on, let it run its course. Can start over, do your assessment. Just because you address something in your assessment doesn't mean that you have to start over. Fix it from that point and go forth. History taken again. Ask your sample history. Blood thinning medication is an important question because if they have any internal bleeding, it's going to only make it worse. Well, we want to know. We want to know what's making it worse. What makes it better? What? That's what I want to know. Why? A history about John Smith, so I can take care of John Smith way better. And then again, right down here, it says determine how much blood has been lost. A good estimation of that is the best thing you can do. So estimate that. Like I said, do that as a little skill. and walk outside, drop your little, a cup of water, and then another spot, go 2 cups of water, and just look at the difference of the pool or how it spreads out across the concrete. It's a neat little tool, little trick that you can see. It's people kind of look at you like, what they doing? Doesn't matter. They don't have to pay attention. If your concrete's dry, everybody's may be wet. So your secondary assessment depends on if you're having to use a manual blood pressure cuff or you're able to use uh, an automatic one. Most of if you use life packs, I don't know much about Zoll, so I can't lie to y'all. But on a life pack, you can hit code summary and it starts printing them out. You can stop it before it gets into their heart rate and rhythm and all that. But if you continue to check it repeatedly with the life pack, you can just print out their vital signs. I always, let me tell you, if you use a life pack 12, 15, or whatever, always, always, always do a code summary before you turn it off. Whew, if I could teach y'all anything, hit that code summary button before you turn it off, or tell your partner, don't touch the monitor, I'm working on it. And then come back and get it afterwards. It's up to you. Your assessment again, assess for your DCAP BTLS, went over that. You want to do all of them, head, abdomen, extremities. You can divide it into the 3 categories. Head is in one, your chest and torso is in one as a second one, and all your extremities. So that's all 3. You can check for a pulse in each extremity and note that, PMS, pulse motor sensory times 4, because that clears your 2 arms and your 2 legs. If you're having in a trauma situation and you take their socks and shoes off and you feel a pulse in each extremity, highly, 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 highly recommend y'all to take a marker, a Sharpie, and not permanent, let's not do that, but like a Sharpie that'll come off with alcohol and mark on them where you felt the pulse, because it could something happen down the road and they may not feel it again, but you did feel it at one time right there. So record that, mark that. Reassessment, we know if it's going to be critical, it's every 5 minutes. Non-critical is 10 minutes. And we're going to assess them completely, do another head-to-toe assessment, document that. Now, granted, if it is a trauma assessment and you are very busy, stuff's going to happen so fast that when you get done, you're going to be like, oh, geez, I don't feel like I really did anything. But when you slowly start typing it and writing it, you know that your full assessment was done in this amount of time, or it was done on this time, and I did this. So think about that over time. What you can do to make your secondary assessment continue to go faster, or your reassessments. So reassessment again is children will compensate well for blood loss, and then they'll crash. So children aren't going to be like, oh, okay, you can look at my vitals, they're going down. No, it's, haha, I'm great. Boom, done. And then you're like, I need ALS. So then you're out of luck because you're already behind the 8 ball. So on children, if you feel that they're going to need any further assistance, reach out to your ALS provider as fast as you can and get them there faster. It's okay to call them there. And then the medic's like, oh no, well, we don't need them down here. I'm gonna cancel. I'm gonna let you take them in. You've already put it in your report. Document that, whatever said to y'all, and rock on. Talking about assessments again. Provide high flow oxygen. We know that. Document. Do not delay transportation to complete an assessment. You can do it en route to the hospital. When you're doing your assessments and it's time for you to determine transportation, don't say, well, I don't want to do it just yet because I haven't completed my secondary assessment. I'm going to transport them. While transporting, I'm going to assess my vital signs every 5 minutes. I'm going to start doing another reassessment head to toe, check for any of the assessments and render of aid that I've already done. I'm going to readdress those, make sure that their blood hasn't gone through that soaking the pad that I put on. Just, reassess that, and you can verbalize that to your proctor, and they know what you're talking about. You don't have to worry about that. You'll be good to go. Oh, let's see here. We talked about communication, documentation. I talked about that a lot. Communicate your findings and interventions used. Document all injuries to care provided to the patient response. Did anything you do improve the patient's health? Did you bandaging their arm improve their blood pressure or their vitals? Did you providing O2, did that decrease their respiratory drive or their respiratory rate? Maybe it's down to when it was at 24 and you gave them 15 liters non-rebreather, you notice they're at 18. That's an improvement. Note that patient had a change to oxygenation. Initial was 22 respirations a minute. After 15 liters non-rebreather, Q5 minutes, I noticed that respiratory rate went down to 18. Document those things. It's cool. It makes you look like you did something. You've got it in documentation that what you did made that patient better. Stay by. Let me see what this one is. Emergency medical care for external bleeding. We know that. Wear your PPE. I don't have to read over that. Wear your full PPE. Make sure the patient has an open airway breathing. Provide high flow O2. Again, if you see right here, life-threatening bleeding is present, control it as fast as possible. Fix that before you say, "Hey, how you doing?" Be like, Scene Safe BSI, I'm applying, direct pressure to this wound and potentially elevate. If it doesn't stop, I'll apply multiple dressings on top of that. Will not remove dressings. I will apply and add direct pressure. I hope that everybody's already going over their skill checks and getting that assessed and memorized. I don't know why it's not going. Several methods available control. You said it right there. Direct, even pressure dressings or splints, tourniquet last resort. Remember that when you do assessments on the patients and your skill stations. Hopefully, a family member is one of your patients currently, and you're able to do it. So when you apply direct pressure, you don't have to try to cut their circulation off. You don't have to be like, "Oh, I've got to tamponade it with the pressure in my arm. I've got this." Ugh. Bro, you're on my neck. I can't breathe. So make it appropriate to where the wound is at. If you applying direct pressure, use your glove, finger, and hand over to do a sterile dressing until you get the 4x4s, ABD pads. You can apply your hand over there. If you find an object protruding in the wound, apply bulky dressing to stabilize the object in place and apply the pressure as best as you can. Never remove an impaled object from the wound unless it is in the cheek and blocking the patient's airway. That's it. It's the only time you can remove anything is if it's impeding their airway and it's in their cheek. Y'all remember that. Side of their mouth. Direct pressure, firmly wrap a sterile, self-adhering roller bandage around the entire wound using 4x4s, ABD pads, anything that's sterile that comes out of your truck. Small wounds, larger wounds if you have to use universal dressings. Cover the entire dressing above and below the wound. And that's what you're trying to do is if it's bleeding out some, you won't want just blood dripping down their arm or their leg because the gravity's pulling it. Just go above and below about an inch, maybe 2 inches. Wrap the wound. So what if you got to use two Curlaces? It's all right. By the time you get to the facility, it ain't bleeding no more, is it? That's their problem. Stress the bandage tight enough to control the bleeding. You should not cut the circulation off. Still check for a distal pulse. If it's on their leg, go down to their feet. Make sure you feel one. Arm, same difference. You got one at the wrist. You don't want to cut off that distal pulse just because you're putting on a bandage. Apply additional manual pressure through the dressing if it's necessary. Add dressings over the wound. Don't remove the wound and apply new ones. Tourniquet. Hopefully everybody knows and understands how to use tourniquet really well. Sometimes we can have hemostatic agents, and as a chemical that slows or stops the bleeding, you may have a clot. I'm gonna tell you that really burns. I just promise you, it really burns. So the use of these agents all depends on what your EMS agency allows you to do. If they allow you to use that, then you have the right to do it as needed. Some agencies don't allow it. They only want you to do direct pressure and bandages and tourniquets and transport to the most appropriate facility. Tourniquets right there. So tourniquet is useful if a patient has sustained bleeding from the external extremity injury. Several types of commercial tourniquets. I'm not going to do the drill, obviously, because I can't see everybody. But you can see on the picture here, you can apply direct pressure. So that's not going to work. Tourniquets are your last resort. High and tight is where they always want them. If it's lower down on the arm, understand you can go below the joint, which is the elbow. That's fine. Or go above the joint if it's they've lost part of their hand, they've lost it from the wrist down. If you can control the bleeding from below the elbow, that's fine. But they always say high and tight is the best way to go. Never be afraid to add two. That is also very important. There's you another picture. I'm assuming they're doing it both with one hand. I don't know, but that's that's a homemade tourniquet. Not real sure what that is, but looks like they're be able to do the job. Um, Observe, let's see, when applying a tourniquet, make sure you observe the following precautions. Do not apply the tourniquet over a direct joint. Always place the tourniquet proximal to the injury. Make sure that the tourniquet is tightened and secure. Never use rope, wire, or belt or anything narrow metal because it could cut into the skin. I have seen that. They got it cut off. They got the blood stopped, but they lost a lot of tissues too because they cut that shit almost completely off their cells because they use wire. It worked, but they got a lot of surgery after the fact. So you use it, make sure it's wide. It's at least 2 inches wide. Most of your tourniquets are approved that way. Make sure they're real tourniquets. You just didn't buy them off Amazon, some old cheapos. So on tourniquets, place padding under the tourniquet if possible to protect the tissues and help with arterial pressure. Never cover a tourniquet with a bandage. You always need to expose the area and apply the dressing. Apply the tourniquet over an exposed area. If it's cold, that's fine. Cover it with a blanket. But if you apply a tourniquet to the upper thigh, the garments, the undergarments need to be leave their panties and their drawers on, but always remove their blue jeans, sweatpants, ski clothes, whatever, so you can see the tourniquet. A lot of pre-hospital cares are going to like the orange, so they're easier to see than the black tactical tourniquets. I really don't know if they're doing air splints anymore, but that's an air splint. Keeps the arm in a position. Obviously, there's a pump to it that applies. That's obviously it sucks that you can see it because the patient may react to it. It's also known as a soft splint or pressure splint. Can control internal or external bleeding associated with severe trauma. So I don't really know if they're teaching those. I will find out, and I will double back with y'all on the next class about those. Let's see here. Air splints. So mobilized fractures act like a pressure dressing. We just talked about that. Why is it not going? Rigid splints. You will see those. You may have cardboard splints. You may have some padded metal splints, some rubber ones. So they will help immobilize the fracture, hold it in place. You have to secure it in certain ways. Like if you got an ankle fracture, you may have to cut it a little bit to get the cardboard splint to the right position. I like cardboard splints. I've used them multiple times. I've even splinted a femur fracture with a mechanical device on with a cardboard splint. So I don't know. I just like them. I think they work cool. They work really well. If you need more training on that, just get them because they're cool. You can cut them in all different positions and make it work. Bleeding from the nose. We talked about this earlier. You may have skull fractures or facial fractures. It could be from a sinusitis or an infection in the nose area. Never let them lean back unless you want to have blood all over you because they vomited. Maybe because of high blood pressure, coagulation disorders, digital trauma, by nose picking. So those can also cause that. My son has his nose bleeds. He could say hello to you and his nose will bleed just because that's how thin his nose walls are. I think it's from his picking his nose. That's just my opinion. So he's over here shaking his head. So epistaxis is common. It is very common about that. Hold on one second. You can, like, we everybody's treated a nosebleed. Pinch it, lean them forward, pinch the nostrils together. Use a 4x4 or some tissue. Once get it stopped, 10 or 15 minutes later, don't pull it away fast because you can pull the clot out. But when you go to pull it out, be prepared for the clot to fall out also. And that being the case is you want to make sure that you're prepared for the nose to potentially start bleeding again and have some other tissues handy in case the clot is rather large and it's going to come out. You want to be able to catch it and contain it, not let everybody in the world see it. Bleeding from the ears or nose, that's very difficult to control. It may be from a skull fracture, may have the halo effect. I always say if you're bleeding from the ear, there's a picture that's coming up. I don't know if y'all can see it, but stand by one. Let me do something. Let's see if I can get this right. All right, there we go. So it may be difficult to control. If you see any type of bleeding, where is it at? Hold on, right there. So if they're bleeding from the ear, wipe it on a 4x4, lay it to the side. If you see it in a halo shape surrounding the blood, so right in here, this is a bad picture, but this is all clear yellowish fluid. That's signs of cerebral spinal fluid. That's very dangerous. You want to get them to the hospital as fast as they can, and because they may have a neurological issue. Most appropriate facility that you can get them to because of that. Document that you see that, document you treated it, what time you found it, and your most appropriate actions there is, keep them in a stabilized position. You don't have to treat them like they're this, oh my God, I don't know what to do, patient, but let's hurry up and get this done because I'm going to freak out. And just take a deep breath. Stabilize them. Don't let them know if they see that you're frazzled, they're going to be frazzled. Sometimes, if you want, put them in a C-collar. You can transport them that way. It'll help you out, kind of to stabilize the brain a little bit more. Emergency care, internal bleeding. Keep the patient calm, like I've always told y'all to begin with here. Provide that comfort care. Give them the high flow O2. Maintain body temperature. It's just if the patient's hot, put them on air. If they're cold, guess what? Your ass has got to burn up in the back of the truck. You got to turn the heater on. I'm a big boy. It's hot. If the patient's cold, I'm like, God dang it. I got to turn the air off. You can add blankets if you have them, but some facilities don't. Some services don't provide the blankets. So just whatever the patient wants, you got to be able to do it to them, yo. Provided those ways. Splinter injuries. There's an air splint, rigid splint, cardboard splint, fun things like that. You may have to use a mechanical device. Really it's kind of assessing your patient. When you make sure things are situated, you transport to the facility, you give them the correct information, provide all of the information. You will document, you'll forget stuff, you'll build a better report, and you'll grow from it. You'll learn. Let's take 10 minutes and we'll be right back. How about that? All right. See y'all in 10 minutes. All right, ladies and gentlemen, thank y'all for coming back. So listen, just want to recap everything. Internal, external bleeding. Internal is the hardest one to see. External is easy to fix. Transportation, patient assessment. It's kind of the same thing. Depends on how we look at them. Each chapter is going to talk about your scene assessment. You might notice that patient assessment. What do we notice about the, vital signs? How to assess them? DCAP, BTLS. Hands-on. What is our rapid transport? Stay in play. It's going to go over that every single time we do this. We're going to give you, some signs and symptoms to look for as you recognize it. I don't expect y'all to be like, oh, they're bleeding from a ruptured liver. I don't expect you to notice that. You're not going to notice that unless you just get these x-ray visions that I'm kind of jealous about. But just know over time what you need to start building your assessments for, how to recognize some things, and to go from there. So, guys, I'm going to pass this on to y'all right here. So, it's the end of the class tonight. We all got homework to do, got a test to take. Your test will, I think, go live in about 30 minutes. So, submit your attendance after you take your test. 8:30, should be done around 8:40. So, before you log off, submit your attendance to Rob. Let him know that this is your class code. And this right here will also be your class test code. It is, let me type this in here, 8T41 exclamation mark. That is your class code for tonight and your test code. That's what you'll need to log in to take your test. Remember, you have 5 days from today to take your test, and that is the 25th. So on the 30th, you will no longer be able to take this chapter's test. Class code again, test code again is 8 Tango 4 1 exclamation mark. Yes, Mal, it is good for 5 days. What about the module test? Your mom, which module, Victoria? Yes, yeah, thank you. If you have not made up any, you have until the 1st to make up for the last module. We run a new module, so I think you're in module 3. If you have not made up module 3, you have until the 1st to take that test. If you do not take it or catch up, what some of the classes, some that may be missing, I know a lot have already caught up. That'd be awesome. No module 2, we have to do that. I'm sorry, I'm confused. I'd have to open up my Canvas to go back and look at it, but since my iPad's dead, it's kind of hard to rec over. But give me a call. All right, so we're going into module 3. So you'll have to complete module 2 no later than the 1st. So module 3 will be later down the road. But each one of these, you're going to have quizzes, you're going to have test codes. You can't go ahead. You can't open the class until 8:30 every single night. So Tuesdays and Thursdays, the class will not be open until 8:30, just to let y'all know that. And in 5 days from the class, they will close. If you don't have the class code because you didn't watch the video or you didn't attend the class, we're going to have issues because I can find out when you watched it, when you logged in, and we'll have to have a one-on-one talk for you to get the code back. Victoria, just call me later and I'll explain what we're talking about. Other than that, folks, I hope you have a great evening. Like I said, your test will open at 8:30. Submit your attendance after you finish your class test. And I hope that everybody has a wonderful evening. If you have any questions, please let me know. I'll be on here for a few more minutes and turn your mic on, or you can private message me and we will talk to discuss it. Or let's talk about it in a group. It's up to you folks. Y'all let me know. I will be muting myself. Y'all have a fantastic evening.